And then you have Thursday to really tie any loose ends that you may have with this. And then Monday will be the exam, and hopefully I won't screw it up like I did yesterday. I've been doing this for 22 years here. This happened once before, about 10 years ago. And it's really my fault because I normally, after I'm done, I go through each question and make sure that it's consecutive. And I do that. So,
Okay. On the recorder, is it supposed to be in folder? No, it's like it just says menu. Like, how do I get out of the menu? Okay, where's the menu at? I don't know why it says okay, it's okay. Okay. But it's like an hour recording already. Okay.
don't forget to sign both attendants, please. All right, let's. All right, come on, guys. Let's settle down. We have a lot of work to do tonight. I don't want to waste any time. Hello. Come on. All right, let's just go through this briefly and see what it's about. So the first page says skeletal system, axial and appendicular. So open to the first page, and you can read along with me. The following represents the bones and their markings that students in A&P 131 need to know. Page 2 and page 2A list all the bones in the human body. Just a reference page. It's good to have that. Page 3 gives the important surface markings of bone. That's vocabulary that you have to learn because that's part of the deal. The human skeleton is divided into two groups, the axial skeleton and the appendicular. The axial skeleton. The axial skeleton forms the longitudinal axis of the body. 40% of all the bones in the human body are part of the axial skeleton. The axial skeleton has 80 bones. The axial skeleton provides the framework that supports and protects the brain, spinal cord, and the organs that are found in the ventral body cavity. Who can tell me what the ventral body cavity is? Yeah. Yeah, but I mean, specifically. What does it entail? Didn't you do this in lecture?
Not yet.
No? Oh. That's usually one of the first topics. All right, so let me just tell you what it is briefly. I mean, here again, when I teach lecture, which is most of the time, I spend a lot of time on the body cavity because it's such an important internal structure. So the body cavities are hollowed areas that allow for the various organs and structures of the body to fit in properly. It's like if you had a box that was, let's say, 2 feet by 2 feet, and you had certain products to put into the box. You'd have to put it in such a way that it would fit. So similarly, in the body, we have these sections, and the body cavities are divided into 2 areas: the dorsal body cavity and the ventral body cavity. So the dorsal is very simple. The dorsal is the cranial cavity, which houses the brain, and the spinal cavity, which houses the spinal cord. And that's really basically it. The ventral body cavity is a little more complicated. So it's divided into 2 parts. The upper part, which is here, is called the thoracic cavity. And down here is the abdominal pelvic cavity. They are separated by the big flat muscle called the diaphragm. So the diaphragm sits like this. On top of it is the thoracic cavity, and on the bottom is the abdominal pelvic cavity. In the thoracic cavity, you have 3 subcategories, or subcavities. The middle is called the medial spinal cavity. You don't have to write it down. I'm not going to quiz you on this. I'm just trying to educate you because your lecture person is supposed to go through all of this. So the middle part is called the medial spinal cavity, which houses the heart, the thymus gland, the esophagus, the trachea, the large blood vessels that go to the heart, such as the vena cava, which is a vein, the aorta, which is an artery, and the coronary arteries, which there are 4, which actually come out of the aorta and then come back into the heart to supply the heart with the purest blood of the body. The diaphragm, and then below it is the abdominal pelvic, which houses the liver, the stomach, the small and large intestines, the gallbladder, the spleen. Anything in back of the abdominal pelvic cavity is called retroperitoneal. And what do you think would be the largest structure of retroperitoneal? Well, it would be the kidneys. Kidneys are in the back. Kidneys are very vulnerable to trauma because they're very superficial. And the only thing that's really protecting the kidneys, which is right about where my fist is, are the big muscles of the back and a good layer of adipose tissue, fatty tissue. So that's the cavities in a nutshell. So, having said all of that, the axial skeleton provides the framework that supports, protects the brain, spinal cord, and the organs that are found in the ventral body cavity. So that's why I just went into that little lecture. Yes?
Did you say it holds 40% of the body's bones?
Yes.
Or, okay. Yeah.
The axial skeleton also provides the structure that the upper and lower extremities are attached to. So if we look at the skeleton over here, all right, so this would be the dorsal body cavity here and the spinal cord. This would be the ventral here and over here. So you can see that the arms are attached to the axial by something called the pectoral girdle, and we'll be talking about that tomorrow. So the pectoral girdle, which consists of the scapular clavicle, attach the upper extremity to the body. Similarly, The lower extremity, the legs, are attached to the axial skeleton by the pelvic girdle. And we'll be talking about that tomorrow as well. So let's continue with this definition here. The upper extremities are attached to the axial skeleton by a structure called the pectoral girdle, which I just mentioned. And the lower extremities are attached to the axial skeleton by the structure called the pelvic girdle. The appendicular skeleton, this portion of the skeletal system makes up 60% of the bones in the body. The bones of the pectoral girdle and pelvic girdle, as well as the bones of the upper and lower extremities, make up the skeletal portion called the appendicular skeleton. So the next page, which is this, in the handout, just gives you definitions of structures that you would find on bones. And I'm not going to go through that. That's something you can look at on your own. But like process, ramus, trochanter, tuberosity, etc., etc. And as you go through the studies of this, these markings will become more familiar to you. Turn the page. So the next couple of pages does give you some classification or some information about the different bones. And here again, that's part of your own study. The vertebral column is here, which shows you the normal configuration. And if you look at it, the vertebral column, it's almost like an accordion. It goes like this. It becomes convex, concave, convex, concave. So you can almost like do this, which would kind of absorb energy. And that's exactly why you have those spinal curvatures. Because every time you jump, they compress to a certain amount, very little, but enough to absorb shock so that your brain is not jostled and damaged each time you run or jump or whatever activity that would cause shock waves to vibrate through your body. The next page is the fetal skull, which we will talk about tonight. And we'll talk about the vertebral column tonight as well, because that's part of the axial skeleton. Okay, so now here's the crux of what you have to know. This page here, which says bones to identify, bone markings to identify, axial skeleton. All right, so let's briefly go through everything that you have to study tonight. All right, we went through all of this, so we don't have to do that again. This is something you can look at on your own in your textbook. This is right from your textbook. If you don't have one or one, you can take a picture of this. It just gives you a little bit of an overview of bones, the axial and the particular. Okay, the axial skeleton has 80 bones. 8 cranial bones and 14 facial bones. Well, you have to know all of that. We'll go through that in a minute. Bones associated with the skull are the auditory ossicles. So let me write that on the board so you will know that. So that's your ear, your outside. This is called the pinna, or the auricle, this part. And then you have a canal, and that's called the external canal. And then you have a membrane here called the tympanic membrane, commonly known as the eardrum. And then you have a cavity here, it's called the middle cavity, which houses 3 small bones. And they basically articulate with each other, of course not like that. So this one is the malleus, M-A-L-L-E-U-S. This is the incus, and this is the stapes. These are the smallest bones of the body. You have 3 in each ear, and they're in the middle ear. The stapes actually articulates with another membrane called the oval window, which then leads to the inner ear, where you have the organs of hearing and the organs for balance. And that we will study, or I should say in lab, we will have eyes and ears as the very last topic of the semester. So, getting back to what we were talking about, 8 cranial bones. Let's look at that. Okay, so if we have a superficial view, these 2 big bones on the top of your head are called the parietal bone, right and left. And they are connected by this zigzag line, and that's called the sagittal suture. Very simple. You know the sagittal divides the body into a left and right component, correct? So, sagittal suture. Easy way to remember. When we are born, the bones are not connected like that. There's a space, and they're connected by fibrous tissue. Fibrous tissue is connective tissue that has fibers. And we're going to be studying the fetal skull a little bit later tonight, and we'll be talking about some of those soft spots that the infant has. How many people here have children? All right, not too many. But most of you know that there are these soft areas on an infant's head that you have to be a little bit careful of. So, why do infants have fibrous sutures, and why do they become solid as an adult? Does anybody have an answer for that? Yes.
Just because the brain is growing still?
What's what?
Is the brain still growing? No?
You know anything else? Any other? Yes.
Is this to help the fetus pass through the birth canal?
Yeah, exactly. So when the fetus is being delivered, it has to go through a canal. And we'll be studying that structure tomorrow, I guess, or Thursday at the latest. So the head of the fetus has to go through this opening. And sometimes the head is bigger than the opening. So the head will actually twist because these joints, called sutures, are flexible. And that allows the fetus to be exited from the mother's body. When that happens, sometimes there's gross disfigurement of the head and face. And when you first look at the child, I mean, you go, oh my God, that's mine. I mean, let's put him back. But it straightens itself out within 48 hours or so, all by itself. So the doctor that delivers that situation should warn the parents, don't be disturbed by this, disfigurement, that it'll go away. That's why when a child is born by a cesarean, they come out looking perfect because there's no pressure on the delivery. Just an incision, lifting the fetus out, separating it from the mother, through the umbilicus, and that's it. And they come out much cleaner and neater, but it's an operation to the mother, so try to avoid that if possible. Okay, so then you have the frontal bone. So this is 1 bone, 2 bones, 3. Frontal bone is up here, and it's separated or connected by the coronal suture. So if you remember, this is the coronal or frontal plane, correct? So that's how you remember that one. So let's look at a different view. So here's a lateral view, and you can see the temporal bone, and that's connected to all the others by the squamous suture. These sutures you do have to know. And then if you look posteriorly, this big posterior bone is the occipital bone, and that's connected by the lambdoid, or lambdoidal suture. So those 4 sutures you have to know: sagittal, coronal, squamous, and lambdoidal sutures. All right, let's look at our handout now. So you can see the frontal bone. What do you have to know about it? Well, it tells you what you can be asked on an exam, and this is what you have to know. So you have to be able to pick out the frontal squama, the orbital margins, and the suborbital foramen. Foramen means a hole. So how do you find these things? Well, you open your book. I'm sure you all have your lab book or your textbook with you. And you find these different things. So, the occipital bone. You have to know the external occipital protuberance. If you run your finger back here, you feel a bump. Everybody do that? That's your external occipital protuberance. There's muscles attached to that. The foramen magnum, the jugular foramen. The jugular foramen is found between the petrous portion. Well, I don't confuse you. All right, the temporal bone, etc., etc., etc. So this handout is telling you what you have to know. Now it's your job as students to learn it. So if you go to the second page, it talks about the facial bones. And the same thing. There are markings on each of these facial bones that you have to be able to identify. And this is only a smattering of the markings. If you open up an advanced textbook like Gray's Anatomy or any of that level of anatomical structures, you'll see each bone may have 20 markings on it, because there are very small markings or indentations that if you're a student of anatomy on a higher level, not a college level, but in a graduate program of some sort of doctoral program or a master's program, you'll have to know a lot more detail. So this may seem like a lot, but it really isn't. Okay, so having said all of that, and I don't want to waste your time with this, the bones are in the case on the table. So each one has a skeleton of a head, and this may not fit properly, but it's backwards. So this is the skull cap, and I'll be interrupting you right through the whole session, giving you different little things that you should know so you can write them down. So this is called the calvarium, Calvarium. So if I said, name this structure, and you wrote down skull cap, what's that? Is that right or wrong? Wrong, right. It's the Calvarium.
How do you spell that again?
Calvarium. Or Calvaria, IA at the end, which is also acceptable. This area right here, where my finger is, which represents right here on you, or me, is called the glabella, Glabella. The reason I'm giving you those two things is because they're not in this handout.
And that's between like the arm and here.
Yeah, it's called the glabella. Okay? All right, so the rest is just follow the guide. If you jump around, I'm going to tell you right now you're going to be confused. If you follow this outline that took me a long time to really come up with all of this, it'll be logical and it won't be wasting your time looking all over the place. So please take out your lab manuals or book, or if you have it on computer, if you have a computer with you. If you don't have anything, then you better buddy up with somebody that has it. All right, so get started. In a couple of minutes, I'm going to go through the fetal skull with you. And I'll be doing this right along the entire session tonight. Okay, so get started, please.
Sorry.
Here you are. Hello.
We're just identifying and looking at the
Is it functional? Turn around the other way. That's small.
I guess
That
sure,
would be
yeah.
the front.
Oh, yeah, I guess we could teach it our own.
Perfect.
That's perfect then.
The external protuberance.
Yeah, that's the right there. Yeah. Alright, got my question covered. Yeah, I said right between your eyes, the point right between your eyes is how I kind of rolled it on his head. Oh, that's so
Everybody, hold on a
smart.
second. Can everybody sign the attendance sheet?
Yes.
Anybody not? So I'll put it away. Can everybody sign the attendance?
Yeah.
Yes.
2 attendants, yesterday and today. Okay. Remember, if you're not on here, you're absent. So, come on, guys, don't waste time. There's a lot of stuff material for the next 3 days.
That is, oh, this is your, this. Yeah. This is, yeah, we can get to that. Yeah, it's your sacrum. Yeah. And then there's also this cell. Yeah, there's that too. That's also helpful to look at. Really, it separates all the sutures and everything. Yeah, right? If you're able to look at it and kind of tell all this.
probably not that. Textbook is much more thorough. You have a book or this book? So bring the actual and that particular with you. Any questions?
I have a question. So,
This one?
it doesn't show the temporal.
This is good.
It's like
In
very.
the suture? Yeah, it's hard to see it sometimes.
Like if you ask for a whole text.
Well, I wouldn't ask for it unless it's some of the skulls have it, some don't.
Okay.
Now, let me see, let you see that for 1 second. Okay, you see this? So this would represent the, right, so the student has the skull, but, you know, when she's paying. Any questions at this table?
Yeah.
Can you help with anything?
Yeah, we like to first though.
Yeah. Try to follow the guide.
Yeah,
Jump all over, I'm telling you, it's going to get lost.
oh. You don't sound really good. Yeah.
So this bonus portion, this area, inside is something called the Petrus portion of the temple. We didn't get to that yet, so I don't want to. Okay. So you should use one of the skulls that come apart. It's better than. Well, yeah, I'll give you the box. So this is the swan's portion of the temporal. You see this like tent? That's called the Petrus portion. I'll talk about it. Not part of it, that is yet. Well, not the left.
Oh yeah, I just meant in that.
Right. True.
Thank you.
Look, this handout is valuable. I don't mean monetarily, but for studying purposes, it really tells the students everything they have to know, rather than floundering and figuring out, well, what is the question going to be? Everything is within here. This is what's one of the what is squamous? Flat. So this is just squamous and squamous. What's similar? It is the outside of it. Yeah, I'm gonna lecture on that in a few minutes. I'll go through that whole thing. This is an important area that we have to talk about. Super orbital one. doesn't really, it's a foramen. Foramen means a hole. Like you see these holes here? So these are all foramen. So this doesn't really show it, but it would be right about, see this little notch here? It would be right about here. It would be the supraorbital foramen. Right, and this is the infraorbital foramen. Here. Yes,
It's kind of by like.
I'm going to go through this, you know.
Like the greater and lesser range. Like a little.
Let me ask you things that you'll be able to see.
Where is the
I also, can I have that? All right, listen. This is an osseous histology model. I'll go through this later tonight. You also have to know this. I have to ask questions, like one or two on this one, histology model. I really went through it the other day when I talked about concentric rings and the lamella, if you remember that. So that's basically what this is about. But I'll go through it again later on. Yes.
I think they're like vertebral discs.
What's your question?
What these were that you was just telling me about. Are these the discs?
Well, those are vertebra, but you shouldn't be up to that yet. You really should try to follow the outline.
Yeah.
Look, you do what you want, but you're going to get confused if you jump all over the place. If you get through the skull and the facial bones, in the next half hour or so, you'll be way ahead of the game.
So this frontal squamous, it's just the
It's your
frontal?
forehead.
Okay.
It's just the forehead.
All right.
I'm going to be going through the orbit of the eye and tell you what it's composed of, but I want you to get familiar with the bones of the skull first, or else it's not going to have that much meaning for you. So I'll wait about 15 minutes and then I'll go over that. Any questions here?
This here. If you want to look at any of this stuff inside of this too, like just
So you can actually see the glandular suture. All of that is.
I just want to back here. Where in this model is this your we can't. Or is it right?
Any questions?
Which one are you looking for?
This supraorbital foramen.
Oh, so 15.
Because like I see it on here, but it's like there's the inferior view of it. Like you can't see it like anterior.
Which is superior?
Inferior actually. Yeah, inferior. So like I know it's like
Yeah, because it's even hard to look up on the
below
diagram.
that. Yeah, so like
I think it's inside the eyes.
yeah.
Yes.
Where specifically hypothetically, if you were to ask about the supraorbital foramen, like what would you be asking us with this? Like, and if so, I'm just trying to look at like the inferior view of it and find it from that. But yeah,
Supraorbital. This is the orbit.
yeah,
Have your pen, please?
yeah.
Okay, so what does supra mean? Above.
Above.
So this is the superior orbit of the eye. I'm going to talk about this in a minute. So see this opening? That's a foramen. This is called the inferior orbital foramen. So the superior is right about here, but they don't show it on these skulls. So therefore, it's just academic to know it, not a weakness is on the test. It's not going to be there.
Okay.
You know, so. Well,
Hypothetically, it's right there. Okay, thank you. I appreciate it.
And the fissure would be inside?
what?
The fissure? If you're looking for the inferior orbital fissure, it's...
No, inferior means below it.
Oh, okay.
As you show the gentleman the inferior orbital.
Inferior orbital, so it would be.
No, that's the foramen. Right.
Oh.
The fissure.
Oh, the fissure, that's inside the orbit.
Right, okay.
Yeah, I'll go through that in a minute.
Okay, I got you.
That's
Thank you.
totally different. I'll explain what a fissure is.
Okay, thank you.
Thank you.
Oh, that looks interesting. What is it?
It's a mango and dragon fruit with lemonade. It's called.
From where?
You get it with lemonade.
Is it bitter?
If you get it with lemonade, yes. If you get it without, it's good.
What is it called?
Mango dragon fruit.
Dragon?
Dragon fruit, like a dragon fruit.
What's dragon? I've never heard of it.
It's like a pink fruit on the outside. You like slice it open, and it's white, and it like has a lot of seeds in it. Yeah,
What?
a lot of seeds.
Oh.
I've never actually eaten it. I've only gotten it.
It's okay, honestly. It's not bad. It's overrated.
Pretty good.
I thought it was raspberry. That's what it looked like. I love raspberry.
Raspberry is delicious. They don't really have any raspberry refreshers. That would be quite the.
A lot of people get the green tea with the lemonade.
That's what I have right here, but they made it too. They made it like sweet. No, I would have Montauk because I must be like
But it's supposed to be a standard formula.
I know, and it wasn't. They don't. No, they didn't make it standard. You know, it didn't really have. I wanted it to be a little bit more bitter. That was the whole point, and it was a little too sweet.
Do they add sugar to it?
They might
The
have.
orbital fin.
They're not supposed to, but I think they did. Which is, I'm not really a fan of that. What did they ask? Oh yeah, this form. The long one, right? It's like the foramen, the whole.
Yeah. And I guess you just need to know superior, inferior, if it's above or below.
But like, if it, like for his purpose, like you couldn't ask that with this
Oh,
body.
yeah, it's not.
Because
Yeah.
it's not there. Like the freemen aren't there.
There's a big hole in the back. Okay, why is the foramen magnum so large? Why do you think? Sorry?
Because it's where your spine is.
Right, because this is, let me show you why.
Where's that?
So if this is the brain, if this is your brain, the brain tapers into a structure called the spinal cord. And you can see at its origin, which is right here, how wide it is. So the spinal cord, as it exits the skull, is at its widest point. It can be up to 1.5 inches wide. So you need a big opening to accommodate
that, and that's why the foramen magnum is so large. What bone is the foramen magnum a part of? It's the occipital bone. And the spinal cord, as it descends and becomes more distal, it gets very narrow, and it narrows all the way down. And when it gets to the sacrum, which you'll be studying, which is a heart-shaped, there's a little tiny hole here, and actually fibers run through that, and then exit through the sacral foramen, which we will do later tonight. What are you up to in lecture? What have you been studying?
I'm chapter 5 now tonight.
Well, what have you studied in the last 2 days?
Yeah.
Or 3 days? Or 4
We
days?
did a lot of, we did chemistry, we did cells,
Did what?
we did like the chemistry, we did cells.
I don't know what you're saying.
We did cells, like cells.
Cell theory.
You know, like cell theory was like a whole chapter. Yeah, chemistry was a whole chapter.
Hydrogen bonds,
Yep.
When you say chemistry, what are you referring to exactly?
Yeah, like different types of bonds and like hydrogen. Yeah. And like enzymes.
You went through ionic bonding?
Yeah. Yeah. So we went through all of that.
So how it becomes an ion?
Yes.
Okay, the energy levels and all of that.
Yeah, the electrons and the codons, the shells and valence.
But it actually, the lab is telling me it's good to hear. Because I already know parts before I'm in this lecture, which helps.
There's no library hours for this?
When I went the other day, they just said that I could come study whenever, but there was no
Well,
order.
that's an
It helps to
advantage.
just be there and have the models.
Wait, the models are there. The models are there.
The models are all
Yeah.
there, yeah, they're in the cabinets, you just give your ID card and then you can.
Well, that's important.
Even if you don't have it, you just put your you know your number.
Yeah.
Yeah, you just write it down.
Your N number.
Yeah, then they just have you sign it on paper.
Well, the designer after like there and study for like 3 hours a night. And I don't understand chemistry at all.
Did you guys find the optic canal?
Which?
We're just gonna go through the
Oh, the
like
optic canal. So it's going to be over here.
right.
So
So is it these little two holes right here, or the space?
the optic canal. Yes. The optic canal are this.
Oh, the 2 holes.
Yep, those 2 holes.
Oh,
Yep.
perfect. Thank you.
Yeah, no problem. All the canals, like, they're all foramen and canals.
It's really not hard. Really simple. And I don't let it go.
I don't know, ain't no rocket science.
What do you explain that? Correct.
When I was thinking of it, honestly, because I was going to take a year, I was going to find a part of it, so I do it, so I don't have to take any extra prereqs.
So this part here is called sorry, let's go here. This is called the temporal portion of the zygomatic bone.
Just apply what anatomy one and two
This is
to the
called
T's, and that's it.
the zygomatic portion of the temporal bone. Those are the two things that make up the arch.
Their back portion is the zygomatic.
And this is the zygomatic bone.
Right.
So this is called the zygomatic portion, zygomatic part of the temporal bone, which is the temporal portion of the zygomatic bone.
Tell me the back one more time.
The zygomatic portion of the temporal bone. I don't like it that
And the front part is the kind of like sheet, the front temporal portion of the zygomatic.
Here, you can see it right here. Here, look up here. You see these two arrows? It says zygomatic arch, correct? So, the zygomatic process of the temporal bone and the temporal process of the zygomatic bone. Right? So if you follow the arrow up, so this is the zygomatic portion or process of the temporal bone, and this is the temporal portion or process of the zygomatic bone.
So like processes and
So together, those two structures make up the arch. And that's a prime question for an exam, and it's always given. And it'll say, name this portion of the zygomatic arch. So if it was pointing to this, you would say the temporal process or temporal portion of the zygomatic bone. I'm sorry, the zygomatic process of the temporal bone corresponds to this.
How would you word the question if you asked?
Yeah, something like that. Name this part of the zygomatic arch. Something like that. And all I have to do is keep my numbers straight. It doesn't matter, I can figure it out. No, I'll be very liberal because of confusion. You like liberal?
what is what? Yeah, so it basically says on there too, like sort of zygomatic process, the temporal or the temporal process.
You know, if it helps to study all of this material, if you enjoy learning about the body, it has to be like in your soul to really want to understand this and know it. Then the study doesn't become a chore, it becomes something of interest. And that's really the difference. If it's a chore, it's not going to work. Like everything else, we don't like doing things we don't want to do. But if you try to say to myself, well, I want to be whatever it is in the medical field, and this is what I have to do to get there, then you'll become motivated for it. I want to go over the orbit of the eye because it's so important. Yes.
When you say orbital margin, do you mean
Yeah, I'm going
each
to
of
talk about that
yes,
now.
you would mean each of them. Okay.
Okay. The orbit of the eye is so important because those of you that are going to become a PA, if you're going for that study or a nurse or whatever, and you're working in an emergency room of a hospital, you're going to have a lot of people coming in with injuries to the orbit. Sporting accidents, car accidents. This is a very vulnerable area, right where my finger is. And a lot of fractures of that. And when that orbit fractures, especially on the lateral aspect, it compresses the eye. And if it compresses the eye for too long, it becomes nephrotic. What's nephrotic mean? Dead tissue. And the person can lose their sight. So if there's an injury and an x-ray or whatever is taken, and you can see that the bones over here on the side are fractured and pushed inward, it requires immediate surgery to take those bones and pull them out and realign them so that the eye is not compressed for any length of time. So you'll see if you work in an emergency room, whether you're an aide or whatever, x-ray tech, you're going to see a fair amount of orbital injuries. So now I want to go through the orbit, and I want you to write it down as I'm telling you, because you have to know this. It's so important. Let me just get to a better picture. Let's see, there's something better down the road here. Okay, so here's a picture, a nice close-up of the orbit of the eye. So you can see the foramen up here. That's the supraorbital foramen, which does not appear on your models. Why, I don't have any idea. But it's very prominent. And then there's an opening here, which is the infraorbital foramen. Infra. Supra, infra. Okay, but let's talk about the orbit itself. So, I want you to think of the orbit not as a circle, but as a square. So if you do it this way, it's much harder to visualize the bones involved. But if you do it like this, so then we have a superior surface, medial surface, lateral, and inferior. Okay, so what bones make up the orbit? The superficial or the supra area is all frontal bone. So there's only one bone that really makes up the upper portion of the orbit, which is the frontal bone. So it's pretty simple. Lateral. So you have two bones. You have the zygomatic anterior and the sphenoid posterior. We have two bones that make up the lateral part. The sphenoid in the posterior aspect and the zygomatic anterior. The medial is the lacrimal anterior bone and the ethmoid posteriorly. The inferior border is the zygomatic laterally, and the maxilla, M-A-X-I-L-L-A, for the rest. So, frontal, sphenoid, zygomatic, maxillar or maxillary bone, lacrimal, ethmoid. So write it down because it's going to be asked. Inside the orbit, there are 3 openings that you have to know. The first one is the highest, and it's called the optic canal. It's for the passage of the optic nerve through the skull. The second 2 are called fissures, F-I-S-S-U-R-E-S. You have the supra-orbital fissure, and then you have the infra-orbital fissure. Those are the 3 openings. They're called fissures because they're like slits. They're not round or oval, but they're slits, so they're called fissures. So this is what you have to know. These 3 openings inside, and the bones that make up the superior border, lateral border, inferior border, and medial border. And the question would be, on the test, it would show a mark, one of those red dots, and it would say, name the anterior bone that is found on the lateral orbital margin. Something like that. Yeah.
What were the 3 inside?
You have to speak louder, I'm sorry.
The 3 that were inside, you said optic?
No. The optic canal,
Uh-huh.
the supraorbital fissure, and the infraorbital fissure. And if you look at your skulls, you can actually see them. Are there any sticks around? Those little sticks?
Oh, it's stickless. Okay, I don't know what they did with them, but. Oh, where'd you find them? Okay, so if you. Do I have that? Here, if you. Everybody, please. Here's the optic canal right here.
Oh, okay.
So if I stick a stick through it, you can see it comes out over here. This portion is called the sphenoid bone. I'll talk about that in a minute. It's really important. This is a whole bunch of foramen, and there are different structures there that you have to know. So I'm going to spend a little time and tell you all about the sphenoid in a minute. And if you work with these sticks, you can poke them through these holes, and it's very helpful to determine what, their location. I don't know where they are.
So this would be where the optic canal is.
They're in the box.
That whole.
Oh, okay.
We used to have a lot of them.
Thank you.
I don't know where they went. Let's see if I can find more sticks.
And then it is
Wow.
orbital fissure.
I feel like that one's easier.
So this is the
I like
top
that it's
fissure,
colored in
this is the
different
bottom
sections.
fissure.
So really easy.
This is the supraorbital, and that's the infraorbital. So like 39A.
I would assume that it should be easier.
Yeah. I think whatever words are on there.
Because then even in the small town,
Hey, what are you looking for? Yeah, so then like if you look from here,
What's the degree?
to the left, oh, and there's the Georgia. Oh my god.
I was the one to check.
Oh my god, really? Okay.
No, I didn't check. I didn't know you posted it.
I didn't think I would have seen something till like this one.
Yeah, I can check it.
Oh my god, I'm gonna love I tried to look it up, like, couldn't find it. Oh my god, maybe I missed it.
It's about to make or break my night.
Right? Like I could have slept peacefully
I was
without
gonna
knowing
wait till
that.
like Thursday or Friday.
Right? Like just figure out how to set it around.
Oh, okay.
There's all prices though, right?
Yes, it's fine. Oh my god, I'm ready. And then it has like
I can't think I could look into like a
What was it? It was a 73. That makes me personal. Huh? New connection uses hotspot. I'm just using connection. I like somehow have connection, but I typically would not. Yeah, I'm gonna do it. I don't.
where do you find it?
You said pulse.
I'm gonna check it.
I was like, I wonder
As if we all check. So go into. I don't really care if you see what it says. Yeah. So okay. So yeah. So go here, and then you go to Wait, where do you find it?
I'll have it on your brain because it's my home.
Maybe.
I definitely did really bad on what is it? Lab. The ones from Upgrade.
The lab one is not here.
Look away.
Lab is not there.
Oh, okay. Oh my God, I didn't do that. Yes. See?
Five.
Thank God I need y'all to stop.
Are you okay?
No. I didn't even see it, y'all.
You didn't see it yet? Okay. You can relax now. Good for you. Also great. Yeah, it's a bright space. Okay, I definitely feel a lot better about my life.
Okay. That's so good. I felt.
I cannot find any sticks, so sorry.
What happened? I gotta stop this. How do you like tell the stats? Yeah, how do you tell like the stats?
That's why I was able to see it on the.
Oh yeah, how'd you say the average? On Pulse? Yeah, let me download that.
What was that part?
It was a 73. Hold on. I mean, I can't connect to it. Oh.
Okay, so if you look in the nasal area of the skull, like that, you will see this bony, separation between the left and right sides. That's known as the perpendicular plate of the ethmoid bone. Together with the perpendicular plate and this little bump that's coming out, which is called the vomer, V-O-M-E-R, those two structures make up the bony nasal septum. So it separates the left and right nasal compartment. Now when you wiggle your nose like this, that's because the cartilage in there is flexible. But that's not the bony nasal septum, it's in back. So when a plastic surgeon does a rhinoplasty, which is a correction of the nose itself, the shape or what have you, they alter that bone because sometimes the bone is deviated and that causes one side to always be clogged or always have mucus coming out. So they can redirect that so it's straighter. Or if the nose is a cosmetic procedure, they can reshape the bony nasal septum. But the two things that I want you to know is that the perpendicular plate of the ethmoid bone and the vomer make up the bony nasal septum. So please note that.
Could you repeat that one more
Read the
time?
whole thing?
Yes, please.
The bony nasal septum is made up of the perpendicular plate of the ethmoid bone and the vomer, V-O-M-E-R. Those two structures make up that bony structure. Now also, if we look over here on the maxilla, you see these little bumps outside? So the teeth sit in a very deep groove in this bone, and it's called the alveolar process. Don't confuse it with alveoli, which is in the lung. Alveolar is the hole in the upper teeth is the maxilla bone that allow the teeth to be so solid because it's very deep. How many people have ever had a tooth pulled here? I know I have. So it's not difficult, but you know that the dentist or oral surgeon, really has to work a little bit at getting that tooth out. Why? Because it's very deep in that cavity. But what I want you to know is that the hole that the teeth sit in is called the alveolar process. And these little bumps here are the protrusion of the canal. I'm going to talk about the sphenoid bone. I just want to get a good picture of it. Okay. What time is it, by the way? 7:48. Okay, so we have about 25 minutes left. So we're looking at the skull this way. In other words, the calvaria has been removed, and we're looking deep inside. So let's go through the real structures that you have to know. Okay, so the sphenoid bone is this blue color. The one in blue is the sphenoid. And it kind of looks like a bat. So there are two parts to the sphenoid. I'm afraid to touch this thing because it always fights back. But anyway, this part up here is called the upper or the lesser wing, Lesser wing. This is the lesser wing. And this big part on the bottom is called the greater wing. So those are the two parts of the sphenoid. Now let's see the markings that you have to know. So if you look inside your model, you'll see there's an indentation right here, right where my finger is. And it has this little bony protrusion coming up. That's called the sella turcica. Sella turcica. Very important. The base of the sella turcica, in other words, the bottom part, all the way down there, is called the hypophyseal fossa. Hypophyseal fossa. Hypophyseal. You know how I can spell it?
Hypophyseal.
So hypophyseal, the same way SEAL. Why is it called the hypophyseal fossa? Years and years ago, the pituitary gland used to be called the hypophysis. So that's why that's the hypophyseal fossa. But we don't call it the hypophysis anymore. We call it the pituitary gland. And the pituitary gland sits inside the sella turcica and is really protected by all the bones that surround it. The pituitary gland is extremely important. It dictates and gives off many different chemicals. And you'll learn about that next semester. Okay, let's see what else is important about the sphenoid bone. Look at all these holes here. So you can't really see that many, but let's go from lateral to medial. So you see this little hole here at the end? So that is called the spinosum, foramen spinosum. The next one, as we're going medially, is oval. It's not round, it's oval, like an egg. And it's called the foramen ovale, O-V-A-L-E. The one that's most posterior and medial here is the lacerum, foramen lacerum. And on the, you can't really see it, but on your model, the one, like almost underneath the lesser wing, is called the rotundum. Those four you have to know. So spinosum, ovale, lacerum, rotundum. And it's all part of the sphenoid bone. On the lesser wing, on the lesser wing, we have this opening, the optic canal. So you see the optic canal on the lesser wing internally, or on the upper part of the orbit in an anterior part, in an anterior direction. You'll also see a hole over here on the side of the medial aspect of the orbit, and that's called the the lacerum foramen, or foramen lacerum. Here's the opposite now. The lacerum is on the side, the medial aspect here. Remember the lacrimal bone? Sometimes it's called the lacrimal foramen. Right there. I'm going to go through the lower jaw, which is called the mandible, in a minute. But anyway. But, you know, I'll let you get back to your own studies for 5-6 minutes, and then I'll go through the lower jaw of the mandible. It's a lot of material, and it's very foreign to you. And that's why you have to study it and digest it slowly. And that's why if you get to the library, even if nobody's there to help you, just to have the extra time to look at these bones and to study it, be very helpful to you. Unfortunately, during the year, we do a project called the Vitruvian Man Project. And that's worth 20% of your bone practical grade. But they don't do it in the summer. So the grade is 100% what you get on the test. So there are advantages and disadvantages. The advantage of the summer, it goes pretty fast. But sometimes it's difficult to digest everything as the course continues. It's a lot of material.
Yeah. Yeah, the biggest one of those is the oral. Yeah. And then the one, like I always said, the one close, like furthest is the spinosa. Yeah.
By the way, if you notice, look at your model again. Inside, and look at the foramen magnum. And you see two little holes on either side? That's called the hypoglossal foramen. You have to know that one. You can see it up here, I think. Hypoglossal, well, it's not really demonstrating it very well. But those little holes are called the hypoglossal foramen on your models. That's important because one of the cranial nerves is called the hypoglossal nerve, and it goes through that opening. Or hypoglossal nerve. Yeah, it even says it right here, hypoglossal nerve number 12. This is the most posterior of the cranial nerves.
Yes. Yeah, hypoglossal nerve. Yeah, so the hypoglossal canal, and then the hypoglossal nerve comes through. So then that's 68. It looks like it would be. So like right here, right? They might have standard.
You have to draw the line on how much a student can take in a short period of time. Giving them plenty of material. I started adding on page by batch. You take an advanced course in that.
Where's the fourth hole?
But you can also already know a lot of the superficial.
Are you talking about the rotunda? The one that's at the top?
We're looking, yeah, we were looking
Trying
at
to, he said identify these four.
Yeah, so like rotunda would be here.
The animal.
Wait. Yeah, would it be like the one closest?
under the-
Yeah. Mhm.
That arch.
Yeah, right there. And then I would say the last one is the furthest in, like this one. Last one, Spinoza, like this is smaller. And the Oval, like, I thought it was the biggest, but I feel like it's the biggest to the right, I would say. Like, you know what I mean? Like, biggest left, the most inside, yeah, most medial, to be your last one. Yes. Ovals. I guess he doesn't want to go with carotid cow. To me, like when I was
This is the hypothesial fossil where that 43 is down there, or
the carotid form is what really gets me.
yes. Yeah, let me just, all right, let me show you this. This is
The carotid.
This is posterior, this is anterior. This is called the crista galli, right here. Crista galli. And on either side is the cribriform plate, which is all part of the ethmoid bone, by the way. And that cribriform plate comes all the way down into the nasal cavity.
Dr. Drummer?
Yeah. Who said that?
Over here. Where's the carotid foramen? Is it because
Carotid?
yeah, carotid, yeah, the carotid.
Okay, on your model,
foramen?
let me have a skull.
Yeah.
Okay, so you have to flip it over,
Okay.
right? And this,
Okay.
and let's see, where is, yeah, right, you see this right here?
Okay.
That's the carotid, but they didn't drill it through.
Yeah, so that's
So
why
I don't know why, but that's the carotid.
So that's it because okay. Is that different than the carotid canal, or is
Well,
the
it's the same
carotid
thing.
it's synonymous for it? Okay.
Canal.
Okay.
Certain things they call canal, I'm not sure.
Okay.
Can I see what we're looking
Yeah, yeah. It's. He said it should be like right here, like that.
This is-
Right here.
No.
No. Right
Maybe
there.
it could be. No, this one. Give me, we don't have any stick.
We do have a
Oh,
stick
yeah.
here. Yeah. We've got a stick
So
there.
this is the carotid right here.
Okay.
Okay.
By the way, if you look at your model, you'll see this big projection over here. That's the mastoid process. So if you put your finger behind your ear and you press on the skull at that point, you'll feel a bump, and that's normal. So don't say, oh my God, I got a bump in my brain. It's normal, and it's called the mastoid process. On little children, it becomes inflamed. It's called mastitis. Very painful. And do you see next to it, on the more medial, is this like projection coming down? It's called the styloid process. What's it? Yeah.
Yeah.
It's a styloid. Looks like a stalactite.
Thank you. Wait, could you put it back into the specific spot in here that the carotid is it right there? Yeah. Okay. Thank you. Okay. Well, luckily I remember it's right here. If anybody wants a picture, I'm going to take a picture. Yeah, sure.
If anybody wants a picture.
Yeah, can you pass that to me?
Yeah, the carotid's important.
See it on there?
Yeah. Yeah, she give me the skull.
Sorry. I can send the photo to anybody who wants it too.
Actually,
All right, so
We're gonna airdrop it.
Yeah.
let me turn mine on.
if you want to look at this, I'll show you. So this is the spinosum, foramen spinosum, this little hole here.
Okay, got it.
And then this is the ovale, see it's oval. And then this is the rotundum, and this is the lacewum. Yeah, so spinosum, ovale, rotundum, lacewum.
My eardrop is purple iPhone.
1, 2, 3.
What?
My eardrop is purple iPhone.
Oh, okay. I'm like waiting for stuff to pop up. We're not popping up right now. I'm not just giving me your phone.
We can do the press thing where you press the phone stick up.
Oh yeah, sure. What do I do? I can just hold it up to it?
I think you could do all you could do.
It didn't work.
I don't know, maybe it's
No,
not.
yeah, but like links our phones.
So like, what is it sending?
Yeah, it's okay.
No, it didn't show up. Maybe just oh, you have my number.
Oh yeah, that's yeah. I have your number. That's why I was.
Okay, that works.
Okay, let's go through the lower jaw.
You would just share my number and I'll send it to you guys. That's fine.
So this is the lower jaw right here,
Oh, just
and you can put it up on the board.
just here.
So this part right here, you can see where I'm pointing.
Share
That
thing with
forms
me, and I'll text
the
it to you.
temporal mandibular joint.
Already text me. I'll send it to them.
So can I have a skull, please?
Yeah, of course. Yeah, of course. You can either, if you like this, just share.
So if you look on the inferior surface of the skull
Just give me your phone
and you follow the zygomatic arch back, you'll see two indentations right here. And that's called the temporal condyle. So the jaw, this part of the articular surface of the mandible,
If everybody's like just texting us.
fits into those, you can see that, forming the temporal mandibular joint, commonly known as TMJ. I'm sure you've all heard of TMJ. The TMJ is an arthritis or a traumatic straining of that joint, and every time you chew, it hurts.
It sucks.
Many people experience that. I actually experienced it when I was in my very early 20s, and I don't even remember the reason. Something inflamed the joint, and for like 5-6 days I could barely eat anything solid. It's very, very disturbing. There are people that have that all the time. And there are treatments for it, but I don't know how successful they are. So anyway, that's TMJ, or the temporal mandibular joint. So let's look at this notch. This is called the mandibular notch. That big dip. And then the anterior part, which is here, is called the coronoid process. Coronoid, N-O-I-D. Right in this part, it's called the ramus, because the ramus is an area that will form an angle. So this is called the ramus of the mandible. This is the mandibular angle over here. And this little hole, can I just stick these? This hole right here is called the mental foramen. This is the mental protuberance. You see these little bumps here? So does anybody have a cleft in their chin? No, a cleft is a hole right in the center. So that happens, like, there's an old-time actor, Kirk Douglas. Anybody remember him? Michael Douglas' father. Anyway, he had this very deep hole right here where my finger is. That's called a cleft. And it's considered to be a thing of beauty, I guess. I don't know how else to explain it. What it actually is that during fetal development, these two parts of the bone don't fuse. And it's actually a deformity. But because there's a gap there, the skin falls in, and that's called a cleft. So, and this is the alveolar process of the mandible. Remember that. Remember, there's one up on top and one on the bottom. Let's see, what else? There's a notch right here. Let me get to that picture. Okay, so the mandibular foramen is on the inside. You can see it on your model. There's a hole right here, right where the stick is. Mandibular foramen. Very easy to remember. Mandible, mandibular foramen. Notch? I didn't mention that. I said protuberance, mandibular protuberance, mental protuberance. Your stick and your jaw. Yeah. What time is it now? Really? Wow. All right, we have 5 minutes left. Let me go over a couple of easy things. This is called the sternum, or commonly known as the breastbone. We never use that term. So this is the sternum. It's made up of 3 bones. Let me get that up on the screen. Oh, by the way, this you have to know. There's a little U-shaped bone in your Yeah, thank you. All right, this is important. This little bone actually is like this right here. This is the only bone in the body, the only one, that does not articulate with another bone. It's strictly for soft tissue attachments, ligaments, and muscles. For the tongue, for the lower part of the jaw, etc. The larynx all attaches to this. And this is called the hyoid bone, Hyoid bone. The only markings you have to know are these little points. And they are called cornues or horns. So this would be the lesser horn, and this would be the greater horn right here at the end. But they're also called cornues, C-O-R-N-U. So what is the claim to fame to this? The only bone that
doesn't articulate with
not
another
articulate with another bone. Here you go. Thank you. All right, let me get a picture of the sternum. And then tomorrow we just have to do the ribs and the vertebra, and then we'll finish with the axial, I believe. Include everything else. Oh, sinuses. This is in your handout. Make sure you know it. I can show a picture of this. And you have to know the maxillary, the sphenoidal, ethmoid, and bronchial sinus.
Oh, okay, cool.
Okay, so here's a picture of the sternum. So the upper part is called the manubrium, which is this. This long part is called the body. And then if you run your fingers like this down your sternum, you'll feel an indentation. Deep in that indentation is the xiphoid process. You're going to give somebody CPR, and you run your finger down their sternum, and you come to that depression. That's where the base of your hand would be to compress their lungs. Put your finger up here. You feel a notch?
Yeah.
Right here, jugular notch. On the sides of the manubrium, here and here, the clavicle, you know it's a collarbone, the clavicle articulates with the sternum at that point. So tomorrow, we'll start with the vertebra, the fetal skull, and the ribs. I think that's everything for the axial skeleton. And then we'll talk about the appendicular. We'll spend that half hour finishing this up tomorrow, and then we'll have from 7 to 8:15 introducing the appendicular. Please make sure you put all the bones back. Close the box. Okay, I'll see you guys tomorrow.
Today? This is it. Yeah, this is all we talked today. That I remember. This is still not growing here. Am I losing it?
It does.
This back in there. Sorry. Yeah, no problem. I actually literally found that on the floor yesterday. My pencil had broke, so I started using that during the exam because.
So tonight's lecture is going to be short, so you get out early tonight, which is always popular. Is this anybody's bedtime, like 10:30? Or earlier. I guess you guys work in the daytime, that's why you take a night class?
Yes.
Yeah. Okay, so let's do the traditional attendance. I think today's the 3rd, right?
Yes.
Yasin? Viviana?
Here.
Gabriella?
Here.
Naya?
Here.
Nicole? Christine?
Here.
Destiny?
Here.
Nohimi?
Here.
Michelle?
Here.
Jennifer?
Here.
Kyle? Jacqueline?
Here.
Taylor?
Here.
Jasmine?
Here.
Joseph? Ashley?
Here.
Justin? Gabrielle, bless you.
Here.
Christy?
Here.
Louis?
Here.
Arthur? Brianna? Desiree?
Here.
Okay, so what is your largest organ?
Skin.
Skin. Very good. You kind of knew that from the slide, right? So it's the largest system in the body. It's 16% of your body weight. There's two major parts, the cutaneous membrane, which is the skin, and the accessory structures, which are the hair, nails, and glands, sweat glands. Components of the cutaneous membrane: you have the outer epidermis, which is superficial epithelium, and the inner dermis, which is made of connective tissue. Usually you always see epithelia on top and connective tissue below it. Remember we said epithelia does not have its own blood supply. So it gets its blood from connective tissue. Accessory structures begin in the dermis. They extend through the dermis into the skin surface. Hair and hair follicles, exocrine glands like sweat glands, and nails. So the integument contains blood vessels and sensory receptors that allow us to feel touch. The subcutaneous layer is the hypodermis, which is made of loose connective tissue and is below the dermis. So let's look at some of the structures. You have the epidermis, the epithelial tissue on top. The dermis, which is this whole section, and this is a sweat gland. This is the subcutaneous layer. Notice the fat. Half of your body's fat is found in the subcutaneous layer. Some accessory structures: you have the hair shaft, the pore of a sweat gland, tactile corpuscles, which detect light touch, sebaceous glands, which secrete oil onto the hair. You'll see that there is something called sebaceous follicles that secrete oil onto the skin. But sebaceous glands secrete it onto the hair. How often do you guys wash your hair? Every day? Who does it every day? Raise your hand. Every other day? Every 3 days? Every 4 days? Once a week?
No one's going to be honest.
Once a week. Yeah, some people are honest. It's actually better not to wash your hair every day because it doesn't strip the oils and damage the hair. So you have the erector pili muscle. What do you think the erector pili muscle does? It's a smooth muscle that does one thing. Any idea?
I'm sorry, what muscle?
The erector pili muscle. This muscle that's attached to the hair follicle. I'll give you a clue. When you're cold.
It stands up your hair.
Yes, it gives you goosebumps. So the erector pili gives you goosebumps. This is a sweat gland here, the hair follicle, lamellar corpuscles, which are here. These detect pressure. The tactile corpuscle detects light touch. The lamellar corpuscle detects pressure. And these are nerve fibers that go to the surface. These in black are nerve fibers. This is a sweat gland. These are capillary beds that you see here, arteries and veins coming together as capillaries. Notice that they're only in the dermis, they're not in the epidermis. Functions of the integument: protection of underlying tissues and organs, excretion of salts, water, and organic waste like urea. Have you ever tasted your own sweat? What does it taste like? Salty. So you excrete salt along with the water when you sweat. Maintains normal body temperature, production of melanin, production of keratin, which makes the skin water resistant, synthesis of vitamin D3. So you can get vitamin D3 by taking a supplement or by exposing yourself to sunlight. Now, I sat in the sun today for about 15 minutes in the backyard with my dog, my golden retriever, at my feet. And I was petting him the whole time. Anyway, so vitamin D you can get from the sun, ultraviolet radiation. Too much of it can cause skin cancer. Not enough can cause deficiency in vitamin D. Half of you in this room are vitamin D deficient. Fully half of you are vitamin D deficient. And if you don't believe me, have a blood test and ask for a vitamin D level. You should probably be taking between 2,000 to 5,000 IUs of vitamin D every day. Some people need 10,000 IUs daily. Storage of lipids, fats, detection of touch, pressure, pain, etc. Coordination of the immune system. So you have the cutaneous membrane, epidermis, and dermis, the accessory structures, the hair follicles, the exocrine glands, the sweat glands, and the nails. Now, something that is very surprising, the outer layer of epidermis is made of dead cells, dead squamous keratinocytes. What do you think hair is made of? Dead cells. What do you think nails are made of? Dead cells. They're all keratinized structures. Now, some people actually grow horns. Horns grow out their head, and they have to have it surgically removed. Now, in the old days, they probably would have killed you if you had horns. They would have thought you were a witch or a demon or something. But we're more compassionate these days. Although we still have war, torture, and I don't think we've advanced much. The epidermis is stratified squamous epithelium. It's avascular. It doesn't have blood vessels like all epithelia. Nutrients and oxygen diffuse from the capillaries in the dermis. Notice these bumps here. These are called epidermal ridges. These are called dermal papilla. They fit into each other. So you notice the depression here is the dermal papilla. The elevation is the dermal papilla. The depression is the epidermal ridge. This is thin skin. And you can see it starts off with living cells, and then it's dead cells at the top, stratum corneum. The cells of the epidermis are the keratinocytes, the body's most abundant epithelial cells, and they contain large amounts of keratin, which is a protein. Types of skin. Thin skin covers most of the body, has 4 layers. Thick skin covers the palms and hands and soles of the feet and has 5 layers. Where do you think skin is the thickest? Bottom of your feet, yeah, your heels. Where do you think skin is the thinnest?
Oh, is it the eyelids?
The eyelids, yes, the eyelids, very good. So this is thin skin. You can see the dead layers on top. There's 5 layers in thick skin, from the basement membrane to the free surface. The stratum basale, the stratum spinosum, the stratum granulosum, the stratum lucidum, and the stratum corneum, which is the outermost layer of dead cells. So here's the stratum basale, the basal layer, stratum spinosum, stratum lucidum. Lucidum means light, like we need light right now. And stratum corneum is the dead cells. How many here use exfoliants on your skin? A lot of women. Exfoliation and desquamation is dead layers of skin cells coming off. So that's what an exfoliant does. It removes the outer dead layers of skin. The stratum basale is also known as the stratum germinativum. It's attached to the basement membrane by hemidesmosomes. Remember, they look like Velcro straps. It forms a strong bond between the epidermis and the dermis. Contains the epidermal ridges, which lie next to the dermal papilla in the dermis. It has many basal cells, stem cells, that replace the ones that die in the superficial region. This is thick skin, fingerprints. Now, do identical twins have the same fingerprints? No. Nobody has the same fingerprints as you. Zebras have distinctive stripes. No one zebra has the same stripes as another zebra. Just a fun fact to throw out in content purposes. Specialized structures of the stratum basale, the tactile disc, tactile Merkel cells with sensory nerve endings found in hairless skin which respond to touch. The melanocytes, which contain the pigment melanin. What did we say melanin does? Protects from UV rays, right. It acts like an umbrella for the stratum basale where mitosis occurs, and it's prone to mutations. What's the worst skin cancer to get? Melanoma, right. That's my wife. So the stratum spinosum is the spiny layer. It's 8 to 10 layers of keratinocytes bound by desmosomes. Remember what desmosomes are. They're like Velcro fasteners that stick cells together. The cells appear spiny when you look at them under a microscope. Produced by the division of cells in the stratum basale, some of which continue dividing. It contains dendritic Langerhans cells, which are active in the immune response. They're actually phagocytic cells, the Langerhans cells, which engulf bacteria and debris. The stratum granulosa is the granular layer. It's 3 to 5 layers of keratinocytes. It's produced from cells of the stratum spinosum. Most cells stop dividing and produce keratin, and keratohyalin, which forms dense granules, which promotes cellular dehydration and cross-linking of keratin fibers. After production of proteins, the cells die. Stratum lucidum, lucidum means clear in Latin. It's found only in thick skin, and it covers the stratum granulosum. The stratum corneum is the horny layer. It's the exposed surface of skin, which is water resistant. It's 15 to 30 layers of keratinocyte cells. Keratinization is the formation of the protective layers of cells filled with keratin. New cells move from the stratum basale to the stratum corneum in 7 to 10 days. I find that interesting, that it takes 7 to 10 days to go from the stratum basale to the stratum corneum. The exposed cells are shed after 2 weeks. Psoriasis is an overproduction of skin. It's too rapid. It produces skin too rapidly, psoriasis. Water is lost from the skin in 2 ways: insensible perspiration and sensible perspiration. Sensible perspiration is what you normally think of sweating. It's excreted by the sweat glands. Insensible perspiration, water diffuses across the stratum corneum and evaporates from the skin. You lose about 500 milliliters per day. And the rate increases if the stratum corneum is damaged, for example, from burns. epidermal growth factor is a peptide growth factor. It's produced by salivary glands in the duodenum of all places, and it's used in laboratories to grow skin grafts. Functions of epidermal growth factor: it promotes the division of basal cells, it accelerates keratin production, it stimulates epidermal repair, and stimulates glandular secretion. What are the glands of skin? What are the three? Sweat glands? Sebaceous glands. Any others? What's in your ear? What's earwax called? Cerumen. Ceruminous glands. The breast, the mammary glands, produce milk in women who are who are pregnant and give birth. The dermis is located between the epidermis and the subcutaneous layer. It anchors the epidermal accessory structures such as hair follicles and sweat glands. It has two components, an outer papillary layer and a deeper reticular layer. The papillary layer consists of areolar tissue. Remember what areolar tissue looks like under the microscope. It looks like spaghetti and meatballs, where the spaghetti is spread out with a lot of space between the spaghetti strands. It contains capillaries, lymphatic vessels, and sensory neurons. It has fibroblasts, which make fibers, like collagen and elastic fibers. It's named for the dermal papilla that project between the epidermal ridges. It becomes inflamed in dermatitis, which is caused by infection, radiation, sunburn, for example, mechanical irritation or chemical irritation, poison ivy. Who's had poison ivy in the past? Raise your hand if you've had poison ivy. Pretty miserable having that, right? How many of you have had sunburn in your lives? Most of you have had sunburn. What do you do with sunburn? How do you treat it?
Aloe.
Aloe? What else? Cold shower? What else? Cry. Solar cane? Avoid the sun, right? Wear sunscreen. That's preventative, but after the fact, you can take aspirin or ibuprofen or naproxen. Helps reduce the inflammation. So if you ever get sunburn, you can take aspirin for it, and it'll help it to go away. It'll help reduce the pain from sunburn. Dermatitis may produce itching or pain. I suspect you probably learned something new tonight when I just told you about the aspirin and sunburn. The reticular layer consists of dense, irregular connective tissue. What is irregular connective tissue made of? The answer is right there. I just realized. Collagen and elastic fibers. You guys can read. Okay. The dermis contains all cells of connective tissue proper, like fibroblasts. Dermal strength and elasticity, the collagen fibers are very strong and resist stretching. They easily bend and twist, and they limit flexibility and prevent tissue damage. Remember, collagen makes up 25% of your body's protein. So if you ever see a test question that says, what is most of your body protein made of? You'll know it's collagen. Elastic fibers permit stretching and then recoil to the original length, and they provide flexibility. Where are elastic fibers found? Give me an example. What's that?
Oh, wait, sorry.
Elastic fibers. Not elastic cartilage, which is found in your ears. Elastic fibers.
Anything that constricts.
When you check your pulse.
9 p.m.
9 p.m. Okay. When you check your pulse, the artery is expanding and contracting because of elastic fibers. The fibers and water provide flexibility and resilience, known as skin turgor. If I was dehydrated and I pinched the skin of my forehead, it would stay pinched for a couple of seconds. And that's an indication of sunburn. It could also be an indication that you're a senior citizen. So you get loose skin. Everything is loose when you get older. Speaking of loose, I was in the nursing home examining a woman, and I was feeling her knees, and I said, "What's this?" And she said, "My breasts." She tucked her breasts into her pants, and they were down at her knees. I just pulled my hands away. Next month, I examined her again, and I said, "What is the swelling?" She said, "My breasts." I did it. I was like, "Oh, I did it again." So things hang when you get older. Things hang. The testicles hang. I don't need to get right. So what's dense, irregular connective tissue? We know it's collagen. Which direction does the collagen go in? Dense regular is wavy and it goes in one direction. Dense irregular goes in all different directions. Collagen is all different directions. And that's what's found in the dermis, the reticular layer of the dermis. Remember we said the papillary layer has areolar connective tissue. Skin damage, loss of skin turgor, is caused by dehydration, which is reversible with hydration, aging, hormones, a lack of estrogen and testosterone, ultraviolet radiation. Excessive distortion of the skin from pregnancy or weight gain may cause stretch marks. Now, bruises are as a result of blood vessels breaking in the dermis. Now, you may have heard of a hematoma. Who's heard of a hematoma? Raise your hand. I call them hematomatoes because they look like tomatoes. When you open it up, it bleeds. It's a collection of blood larger than your finger, like the fingertip, is a hematoma. So this is the dense, irregular connective tissue that I was telling you about, running in all random directions. Collagen and elastic fibers. Tension lines are cleavage lines produced by parallel bundles of collagen and elastic fibers in the dermis. They resist forces applied to the skin, and a cut made parallel to a tension line remains shut and heals well. A cut at a right angle pulls open and scars. So these are the tension lines. Notice this is the front on the right side. Notice the tension lines. The collagen runs in one direction. When a woman has a cesarean section, they will make the incision along the line to reduce scarring, so she can wear a bikini without a scar. On the face, plastic surgeons use the tension lines to know where to make the incisions so to minimize scarring. So an incision going up and down the tension lines produces scars, whereas the ones that follow the tension lines form less scars. Dermal blood supply, you have the cutaneous plexus, which is a deep network of arteries along the reticular layer. The subpapillary plexus, which is a network of small arteries in the papillary layer. The capillaries drain into small veins that lead to larger veins in the subcutaneous layer. So we said what a contusion is, or a bruise, is caused by damage to the blood vessels in the dermis. This is the papillary layer. This is the reticular layer. And you notice the capillaries in the dermal papilla. And you have the subcapillary plexus, and the cutaneous plexus is in the reticular layer. And what is this yellow stuff? Fat, right. Innervation of the skin. Nerve fibers in the skin control blood flow, adjust gland secretion rates, and monitor sensory receptors. The sensory receptors respond to light touch, the tactile or Meissner corpuscles in the dermal papilla, and the deep pressure and vibration are the lamellar or Pacinian corpuscles in the reticular layer. The subcutaneous layer is the hypodermis, which lies underneath the dermis. It's really not part of the skin, the subcutaneous layer. It's below the skin. It's connected to the reticular layer by connective tissue. It stabilizes the position of skin, and it's primarily adipose tissue. Large arteries and veins are in the superficial region of the hypodermis. It's the site of subcutaneous injections using hypodermic needles. Distribution of subcutaneous fat is determined by sex hormones. And women tend to get weight on their hips and buttocks. Men tend to have small buttocks and big bellies as they stop working out. What type of injection is used in a tuberculin test? It's not subcutaneous. What type of injection is it? Intradermal. Intradermal. It's in the dermis. And you raise a little bubble with the PPD, purified protein derivative, which is a test for tuberculosis. You read it after 2 or 3 days, and you check to see how much bump is there. So this is the subcutaneous layer, a lot of fat and blood vessels. Skin color is influenced by 2 pigments, melanin and keratin. Melanin is the red, yellow, or brown, black pigment produced by melanocytes. It's stored in intracellular vesicles called melanosomes, and it's transferred to keratinocytes. Dark-skinned people have large, numerous melanosomes, and it protects the skin from ultraviolet radiation. Small amounts of UV radiation are beneficial to raise vitamin D levels. Too much can cause damage to the DNA and cause cancer. Keratin is an orange-yellow pigment found in orange vegetables, like carrots. Accumulates in the epidermal cells, deep dermis, and subcutaneous layer. It can be converted to vitamin A, which is required for the maintenance of epithelia and the synthesis of photoreceptor pigments in the eye. Now, how many of you had mothers that told you if you eat carrots, it'll improve your vision? Raise your hand. Okay. That's true because it increases photoreceptors in the eye and gets converted into vitamin A. Now, there have been cases where people have gone on an all-carrot diet to lose weight. They only eat carrots for every meal, breakfast, lunch, and dinner. Guess what color they turn? Orange. They turn orange. And until they get off the diet, and it takes about a month or 2 to restore their normal color. It has happened. My mom used to make me eat brain, cow brain. How many people have eaten cow brain? Raise your hand. One person. Okay. She told me if I ate cow brain, it would make me smart. And it worked. So this is melanin in the basal layer of a dark-skinned individual. And this is a melanocyte. It looks like an octopus with various tentacles. And these are melanosomes. So it injects melanin into the keratinocytes. Blood flow and oxygenation influence skin color. Hemoglobin is bright red when bound to oxygen. Why did we say blood is red? What is it?
That's what you see when it comes. Why do we say it's red, you said?
The iron.
Why?
Oxidization.
The oxidation of what? Iron. Remember, rusted iron is red. When blood vessels dilate from heat, the skin reddens. It also reddens when you're embarrassed about your test scores. When blood flow to the skin decreases, the skin pales. Hemoglobin turns dark red when oxygen is released. It can result in cyanosis, which is bluish skin. It can be caused by extreme cold, heart failure, severe asthma, and death. Have you ever noticed that someone, when they die, they turn white? They become completely pale. They lose their color. They've actually done studies when people die, they lose some weight. We don't know why, but there's a weight difference. Someone who's alive to someone who dies. There's a small weight difference. Illness and skin color. Jaundice is the buildup of bile produced by the liver. The skin and whites of the eyes may turn yellow. Now, you may not see it on the skin, but you'll see it on the eyes. The white of the eyes will turn yellow. A pituitary tumor can produce excessive melanocyte-stimulating hormone, which increases the production of melanin. Addison's disease causes pituitary gland to release excess adrenocorticotropic hormone, ACTH, which has a similar effect to melanocyte-stimulating hormone. And the thing about it is that an example of someone with Addison's disease is John F. Kennedy. He always appeared tan. Now, he spent a lot of time on his sailboat, but in the winter, he wasn't on the boat, and he still was tan. It's because he had Addison's disease, and he was making too much ACTH. Vitiligo is the loss of melanocytes causing the loss of color. This is vitiligo. And Michael Jackson had vitiligo. I don't know if you guys know who Michael Jackson is. Yeah. Vitamin D3 is called cholecalciferol. It's produced by epidermal cells in the presence of ultraviolet radiation. The liver and kidneys convert vitamin D3 into calcitriol. That's the active form of vitamin D, calcitriol. It's essential for the absorption of calcium and phosphate ions from the small intestine. Insufficient vitamin D can cause rickets. We'll show you an example of rickets in a second. So sunlight takes steroid compounds and converts them to cholecalciferol. Dietary cholecalciferol you can get from milk, vitamin D3. The liver converts it to an intermediate product. The kidney secretes calcitriol, which stimulates calcium and phosphate absorption from the small intestine. Now, people who have deficiency in vitamin D tend not to absorb calcium as much, and they're more prone to develop osteoporosis, which is thinning of the bones. This is an example of rickets. Notice the bowing of the legs. Bowing of the legs, caused by a deficiency of vitamin D. Accessory structures of the integument: hair, hair follicles, sebaceous, sweat glands, and nails. They're derived from embryonic epidermis. They're located in the dermis, but project to the skin surface. Hairs cover almost all the body, except the palms of the hands and sides of the fingers, the lips, and portions of the external genitalia. So one of the first signs of mental retardation is the growth of hair in the palms of your hands. The second sign of mental retardation is looking to see if you have hair growing up from your hands. Functions of hair are to protect and insulate. It guards openings from particles and insects, and it serves as sensory receptors. There's different types of hair follicles. It extends deep into the dermis. It produces non-living hair. So your hair is dead skin, dead cells. It's wrapped in dense connective tissue sheath. The base is surrounded by sensory nerves called the root hair plexus. The root hair plexus, if you've ever had an insect crawling on your hair, you can feel that insect because of the root hair plexus. The erector pili muscles cause involuntary smooth muscle contraction to cause hairs to stand up and produce goosebumps. The hair root is the portion that anchors it into the skin. The hair shaft is above the skin, the upper part of the hair. So here's some of the structure. Here is the root hair plexus, the nerve fibers that cover the hair follicle. This is the erector pili muscle. This is a sebaceous gland. This is the hair shaft above the skin. And there's the fat of the subcutaneous layer. This is called the hair bulb. Has anybody ever pulled a hair out and seen a little white thing at the end of it? That's the bulb of the hair. We'll skip the layers of the hair because I can never remember them. So this is the hair matrix. This is the part of the hair that actually is alive. Only this portion of the hair is actually living. This is the hair papilla. In the hair papilla, the hair matrix is fed by capillaries, which allow nutrients to go into the hair matrix. So here's the hair papilla with the blood vessels. Here's the hair matrix, the only living part of the hair. The hair structure, we're going to skip. We're going to skip the layers of the follicle. Hair production begins at the hair bulb, at the base of the hair follicle. It surrounds the hair papilla and connective tissue containing capillaries and nerves. At the base of the hair bulbs, epithelial cells form a layer known as the hair matrix, which produces hair. As the cell divides, hair is pushed up and out of the skin. Types of hairs. Vellus hairs are soft, fine hairs that cover most of the body. Terminal hairs are heavy, pigmented hairs on the head, eyebrows, eyelashes, and other parts of the body after puberty. For example, the underarms and the pubic region, pubic hairs. Have you ever noticed that eyelashes and eyebrows don't grow, but your hair on your head grows? Let me ask you a question. Who has more hair on their body, men or women? It's a trick question. It's the same amount, except women have more vellus hairs and men tend to have more terminal hairs, the heavy pigmented hairs. Same amount of hair, though. The exocrine glands in the skin, the sebaceous glands, oil glands, are holocrine glands. In other words, the cells die and they release the sebum, the oil secretion, which lubricates and protects the hair shaft. It also inhibits the growth of bacteria. Now, when the sebaceous glands are clogged with bacteria, it produces acne. So acne is an infection of the sebaceous glands and the hair follicles that the sebaceous glands come out of. The sweat glands, apocrine sweat glands and eccrine sweat glands, will go into the difference between the two. Types of sebaceous glands we're going to skip. The ones that are associated with hair follicles are known as sebaceous glands. Sebaceous follicles are large sebaceous glands that are not associated with hair, and they discharge the oil, the sebum, directly onto the skin surface. They're located on the face, the back, the chest, the nipples, and external genitalia. So this is a sebaceous follicle. Notice that it has a pore that goes to the skin. This is a sebaceous gland that is attached to a hair follicle. What is this nerve ending called? the root hair plexus. What is the living part of the hair called? Hair major. What is this little indentation where the blood vessels are? The hair papilla. This is a diagram of a sebaceous gland opening into a hair follicle. This is the lumen where the hair would normally be, and the hair follicle has been removed to show you the sebaceous gland. So this is an actual light micrograph view of a sebaceous gland. Notice the cells die. They're alive down here, and they die and burst and release their oil at the top. Apocrine sweat glands are found in armpits, around nipples, and the pubic region. They're not found until puberty. So that's why children don't have to wear antiperspirant or deodorant on their armpits, because they don't produce apocrine sweat. And it secretes products into the hair follicles via merocrine secretion. It produces sticky, cloudy secretions, which are a nutrient source for bacteria, which cause odors. So the odor is not caused by the apocrine sweat, it's caused by the bacteria that break down the apocrine sweat. Something interesting about apocrine sweat glands. When women live together, let's say 4 women live together, their cycles, their menstrual cycles, will line up to the same time of the month. And they found the reason for that is the armpit. The apocrine sweat glands are smelled by the women. There'll be one dominant woman that will give off a pheromone from the armpits, and all of the other women will cycle with that dominant female. Now, it doesn't mean dominant like she's a dominant personality or anything like that. It just means that her cycle is the cycle that makes the other women have the same cycle. Now, you might wonder, how did they figure that out? Well, they took cotton balls and put it under the underarms of women, and they had them sniff the cotton balls. And the ones that sniffed the cotton balls from the dominant female all had the same cycle. Pretty weird, right? Weird experiments. So this is an apocrine sweat gland. Notice that it opens onto the hair follicle. The eccrine sweat gland opens onto a sweat pore. So that's the difference. The apocrine sweat gland opens onto a hair follicle, whereas the eccrine sweat gland opens onto the skin pore. So eccrine, merocrine sweat glands are coiled tubular glands that discharge directly onto the skin surface and provide sensible perspiration. They're widely distributed on the body surface, especially on the palms and soles. Secretions are 99% water plus salt. And one other thing that it excretes is urea, which is a nitrogenous waste. When protein breaks down, it breaks down into nitrogen. Your body has to get rid of the nitrogen. One of the ways your body gets rid of nitrogen is in your kidneys. The other place where it gets rid of the nitrogen is in your skin when you sweat. Functions of eccrine sweat glands: cooling of the surface of the skin to reduce body temperature, excreting water and electrolytes, and providing protection from environmental hazards. Now, a test question would be, what lowers your body temperature? Apocrine sweat glands or eccrine sweat glands? What would be the answer? Eccrine sweat glands. Apocrine sweat glands don't lower your body temperature. The eccrine sweat glands are the ones that lower body temperature when you sweat. So again, this is the eccrine sweat glands open to the skin, sweat pore. The apocrine sweat glands open onto the hair follicle. Other integumentary glands are the mammary glands that produce milk. The ceruminous glands would produce cerumen or earwax. which prevents foreign particles from reaching the eardrum. Let me ask you a personal question. How many of you use Q-tips in your ears? Raise your hand. A lot of you. And then you know what they say, never put anything bigger than your elbow in your ear. But I do it, and I'm a doctor. I use Q-tips in my ears. They say, supposedly, that when you use a Q-tip, it pushes the wax deeper into the ears. I haven't found that to be the case. My wife doesn't use Q-tips in her ears, and she has to get the wax cleaned out every 6 to 12 months. Now, don't tell her that I told you that. She'll be very annoyed. Control of glands. The autonomic nervous system controls sebaceous and apocrine sweat glands, and it affects glands throughout the body at once. The eccrine sweat glands are controlled precisely, and sweating may occur locally. Thermoregulation is the main function of sensible perspiration. The eccrine sweat glands work with the cardiovascular system to regulate body temperature. Nails protect the tips of fingers and toes, and they help you collect quarters when you have to put the money in the meter. It's made of dead cells packed with keratin. In other words, like hair and skin, dead keratinized cells. Metabolic disorders can change nail structure. For example, pitted nails result from psoriasis. Now, which do you think grows faster, your fingernails or your toenails? Fingernails. You don't have to trim your toenails as frequently as you do your fingernails. Now, I have a personal confession. I get a manicure, and I get a pedicure. No nail polish, though. It's getting really personal. Probably too much information to get in mind. The structure of the nail is the nail body, which is the visible portion of the nail, covers the nail bed, which is underneath the nail. The sides of the nails lie in lateral nail grooves. It's surrounded by lateral nail folds. The skin below the distal free edge is called the hyponychium. And has anybody ever cut their nails too short? It hurts, right? You're cutting into the hyponychium when you cut your nails too short. You'll see what it looks like in a second. Nail production occurs in the epidermal fold called the nail root. Remember we said the hair matrix is where hair, the living part of hair is. The living part of the nail is found in the nail root. It's the deepest part that lies very close to the bone. The visible nail emerges from under the part of the nail root known as the eponychium or the cuticle. And how many of you go to a Korean or Chinese nail salon to get your nails done? How many of you think they're talking about you in Chinese? Okay. Paranoia strikes deep. Near the root, blood vessels are obscured, producing a pale lanula. Now, some of you have a lanula. Check your fingers and see if you have a lanula. How many people here have a lanula on your nails? Half of you have lanulas. It's nothing bad, don't worry. This is the nail fold here. The cuticle, which in Chinese and Korean nail salons, they push the cuticle up and they trim the lateral nail fold with clippers. This is the nail body, and the nail bed is underneath the nail body. These are the lateral nail grooves, lateral nail folds. I'm probably giving you too much information. You probably don't want to know about nails, but I'm giving it to you anyway. This is the nail root. This is the lanula, the nail body. And here's the hyponychium. And this is the free edge here, the free edge. Repair of the integument following an injury. Bleeding, swelling, and pain occur. Mast cells trigger an inflammatory response. A scab, dried blood clot, stabilizes and protects the area. Macrophages clean the area. Fibroblasts and endothelial cells divide, producing what's called granulation tissue. The inflammation phase, let me make this bigger. Bleeding occurs at the site of injury. After the injury, mast cells in the region trigger an inflammatory response. And this poor kid has a laceration on his forehead. And so you get bleeding at the site. Only if you cut into the dermis. Mast cells are releasing their histamine, and the histamine dilates blood vessels and brings more blood to the area. Why is that a good thing? Why would you need more blood into a laceration? That's kind of weird, isn't it? Counterproductive.
Like coagulated?
It's bringing platelets to the region to help coagulate the blood. In the migration phase, after several hours, the scab has formed and the cells of the stratum basale are migrating along the edges of the wound. Phagocytic cells are removing debris, and more of these cells are arriving with enhanced circulation in the area. Clotting around the edges of the affected area primarily isolates the region. So you have a scab formation here. It sounds like such a dirty word, scab. The proliferation phase is about a week after the injury. The scab has been undermined by epidermal cells. Notice, here's the scab. These are epidermal cells growing underneath. This is scar tissue that's formed by fibers of the fibroblasts. So how many of you guys have a scar on your body? Raise your hand if you have a scar. Okay, most of you have a scar. And eventually, the epidermis straightens out and scar tissue forms underneath. And you have a little depression here. But the depression doesn't last. It eventually makes it smooth with the rest of the skin. Repair of the integument following an injury. The clot begins to dissolve. The number of capillaries declines, and non-cellular scar tissue is reduced. Now, some people form keloids, which are excessive growth of dermis. And this is what a keloid looks like. Every time a person who makes keloids has a laceration, they form these scars that are raised. I won't ask how many of you have keloids. I don't want to embarrass you. The effects of aging on skin. The epidermis thins. The number of dendritic cells decreases. Now, to give you an example of how the epidermis thins, in nursing homes, a lot of older patients, when you pull on their arms, it tears their skin. Their skin is so thin that it actually tears and they bleed. Vitamin D3 production declines. Melanocyte and glandular activities decline. So people get white hair or gray hair. Blood supply to the dermis is reduced. The function of hair follicles declines, and I'm a perfect example of that. The hair thins. Dermis thins, and elastic fiber network shrinks. Sex-specific hair and body fat distribution fades. So, what was that? So men tend to have more hair loss, and it's because of testosterone. Testosterone. If you ever see a man that's balding, take pity on them. They have too much testosterone. And body fat distribution fades, and hence the breasts tucked into the pants. And repair rate slows. So that's it. So we're finished early. Any questions on what we covered? Okay. Have a good day.